Welcome everyone to today's webinar, AI for Stronger Surgical Programs, Tips from 4 Health Systems, sponsored by Surgical Safety Technologies. I am Mariah Muhammad with Becker's Healthcare. Thank you so much for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will start today's webinar with a presentation, and there will be time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Don't forget to check out our resources section for additional information and fill out our session survey. Both can be found on the right side of your screen. If at any time you do not see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are always here to help. Again, thank you so much for being here today. At this time, I'm pleased to turn the floor over to Dr. Jennifer Huck to kick off our discussion.
Thank you. My name is Jennifer Hauk, and I'm moderating today's discussion. Today, I'm joined by Douglas Smink. He's the Chief of Surgery at Brigham and Women's Faulkner Hospital, Vice Chair of Education at the Department of Surgery at Brigham and Women's Hospital and Harvard Medical School. Doug's research focuses on resident and faculty education and patient safety through simulation, team training, and coaching. Brigham and Women's has been using AI technology in 2 of their ORs since 2023. We also have Celia Davino, who's the Division Chief of General Surgery at Mount Sinai. She's a professor of surgery, the Vice Chair for Education and Quality. Celia oversees the Quality Assurance, Surgical Education, and Performance Improvement Committees and the NISQIP program. As the Vice Chair for Education and Quality, she instills a culture of safety in the education of house staff, highlighting the importance of team training and pathways to improve patient care and reduce medical errors. Mount Sinai has had AI technology in 17 ORs since 2021. We also have Dominique Watt. She's the Executive Director of Clinical Effectiveness and Education on the Interventional Platform at Stanford Medicine. Dominique has had over 13 years of experience in leadership roles, including the Interventional Platform, Inclusion, Diversity, and Health Equity, and Peri-Anesthesia Services. Dominique is a Lean Six Sigma Black Belt and a clinical nurse leader. And Stanford currently has AI technology in 14 ORs since 2021. And I'm an assistant professor of anesthesiology in the neuroanesthesia division at Duke Hospital. I lead the Black Box Committee, and I'm a member of the Anesthesia Patient Safety and Quality Committee. My passion is creating a culture of safety in the OR, where everyone has an equal voice to bring up safety concerns. At Duke, we have AI technology in 7 ORs and 1 trauma bay since 2020. So just to level the audience, let's take a quick moment to provide clarity on the technology and infrastructure that was put in place at all of our institutions to support AI to improve care. The technology is called OR Black Box that we're talking about. It has video cameras to capture activities and team dynamics. It has audio recording via microphones to capture the dialogue. It's integrated with surgery video recording devices such as robots and laparoscopes. It also has anesthesia device integration to capture the physiologic data, and as well as EHR integration to capture demographics and patient data. The goal is to capture everything that happens in the OR so we can detect anomalies and analyze events, and ultimately make the changes to improve patient care, processes, and operations. There are lots of ways to use this technology to improve patient outcomes and OR efficiencies. So Doug, let's start with your work at the Brigham. How have you integrated this technology in your ORs?
Hello, everybody, and thanks, Jennifer, for that question. We, as you heard, are honestly probably latest or some of the latest to the game here, just joining the Black Box Network just last year in only 2 of our ORs. I would say there's lots that drove us to do that. In general, I think that we at our institution and all of your institutions provide incredibly high quality, safe surgical care. But if we really want to take surgical care to the next level, we need to take advantage of technology that exists. And we need to open up the operating room, the place that's been generally very secretive for decades, and use video and audio and analysis to try to improve how we deliver care. There are lots of ways to do that using the black box and other AI technologies. And I would say with my interest, very interested in looking at team dynamics, and that was one of our drivers. We've done work with coaching and have thought about how we could use the black box for coaching and really focus on performance improvement of any member or all members of the team. That said, when we first started, we have focused a lot on the safe surgery checklist. Why we've done that is in part because it's very measurable, and it gives us actual numeric metrics that we can track and we can try to address. It gave us insight into our performance as a team. We use the checklist and have used it for over a decade, but that doesn't mean we always do it well, and we know that's true at all of our institutions. And this really gives us a window into actual performance rather than performance on the checklist that you may get through an audit where somebody comes into the operating room with a clipboard. So the ability to understand our compliance with the checklist, the engagement of the team, and the actual connecting on all the different aspects of the checklist was really important to us. I also think an important reason to look at the checklist is because we've seen through multiple studies that the checklist does directly correlate with patient outcomes. And also it's probably a little more comfortable of a place for team members to start with when you introduce this technology. It's uncomfortable to people to know that they're being videotaped and audio taped in any aspect of their life, but particularly when they're doing their work, and particularly in the operating room. But we're all part of the checklist, and it's a sort of a safer, less specific about individual performance way of measuring how the team is working that we felt was a good place to start.
Thank you, Doug, for your comments. Just curious, Celio, how about you at Mount Sinai? How have you been using this technology to improve efficiencies and outcomes?
Thank you, Jennifer, and thank you to Beckers for the opportunity to be part of this webinar. So adding to Doug's point, we've also used this technology at Mount Sinai to essentially improve and optimize our efficiencies and patient outcomes. We initially started with 2 pilot ORs, and we collected aggregate data for about, I think, 3 years before we expanded. So if you go from that, you must realize that there must have been some valuable data that we were able to accumulate to drive more ORs, so that we now have a total of 17 and 15 encompassing most of the major subspecialties within the hospital, which is a very important point we try to do, because I think it's very important. First of all, the black box technology sets the stage for a culture change in how, we perceive quality and safety. There is a push for, as Doug said, the operating room is a secretive place where no one talks about what happens. There's a culture of transparency and self-reflection based on very accurate, good data and not some manual audits that is important in driving our PI projects and process measures. So and I think it's very important as head of education, it also is a very ideal place to start with young surgeons in training, so that it's a different culture that they are coming into. Secondly, we have started utilizing case reviews that highlight how things should be done or how process should be improved. And we use them in our teaching conferences while emphasizing the importance of really what happens in the OR, which is this is a multidisciplinary platform, in the operating room. And lastly, as we have expanded, you also have to take into consideration sustainability. We have focused on improving our key performance, indicators, and we identify those every quarterly and, change them as needed. And we take really suggestions from each member of or representative of each department on what they think is important. but to focus on some key performance indicators and see if we've made a dent on that is very important. In addition to key performance indicators, there is a priority being put on the return of an investment. 17 ORs ain't cheap. So we also are looking at return of investment. With the black box technology, you can optimize efficiency, and maybe I can go into that a little later. But at least we have the opportunity to look at each step of the process. And, interestingly, it has allowed us to bring new technologies to Mount Sinai by incorporating it and maximizing the maximizing the use. For example, as we have expanded into neurosurgery, the microscopes are already part of the system. In neurology, that does robotic um, predominantly, we have incorporated that as part of our data system. So there are a lot of things from education, research, as well as just plain performance improvement involving the entire, spectrum of people working in the operating room has been, made possible by this technology.
Thank you, Celia. Those are great examples. Doug, what do you see as the biggest patient safety risks that AI tools are helping mitigate during surgical procedures?
So I think I'll give you an example of one that we've focused on a lot. There are so many aspects that I think the black box can touch on. A really good example that we've used around quality and safety that black box helped us identify was around the debrief and specimen handling. So as most of you know, at the end of the case, there's a portion of the safe surgery checklist is a debrief where we discuss the procedure, the specimen that was removed, if there was one, and it wasn't correctly labeled. And we identified, we had some concerns about our process around specimen handling before we had the black box data. And the black box data really helped drive home that we had areas for improvement. You get feedback on whether all aspects of your safety checklist are completed. And we could see that the debrief was the area that we were performing the lowest on that scale. Not to say that it's different than other institutions. I think we know that that's a challenge across our institutions. But we were in the process now of trying to put together education around the debrief and specimen handling. And the beauty of the black box is that we can use our data and track it over time and see if we see improvement. We can also create videos to educate people on how best to perform the debrief using actual videos, not something that's simulated, but we can take video from our actual ORs, a team performing well, and then be able to share that with our staff, with newly hired members of the team that can be really beneficial for quality improvement in that area, for example.
Excellent. That's a great example, especially how you can translate use of these videos into education and teaching best practices. One of our focuses at Duke has been a multidisciplinary use of black box for quality improvement. So for example, we held our first multidisciplinary grand rounds that included surgery, anesthesia, nursing techs, and any other OR staff and surgical attendants. And together we reviewed an intraoperative code after a patient was induced under anesthesia. And we used this black box technology. And we noticed how each discipline contributed to the resuscitation of the patient. And as a team, we identified 2 specific QI projects for our task forces to address. And we've also used the technology to improve processes like turnover. We've individually analyzed multiple turnovers to see what team members are doing during each point in the turnover, how they're using their time. And we wanted to figure out what are ways we can do more parallel work and reduce any barriers that extend the turnover time. And to Doug's point, we've also been using it to look at specimen handling, and as well as surgical site preparation compliance. Dominique, let's talk about Stanford next. Tell us how you're using this technology.
Good morning, everyone. Stanford's still in the morning. So hi, everyone from the West Coast. And just listening to everyone talk about their organizations, I think what gets me most excited is how common our opportunities are in the surgical and interventional space, which is why I get so excited for this product, because it brings us all together in this network, and not only looking and using the product, but also evaluating our processes. And if I can just share a few things we're doing at Stanford, very similar to the examples that were shared, but just learning to optimize and work smarter. So at Stanford, we, and I oversee quality and education, so similar to what was shared, we are looking at improving counts with accuracy and time required to complete the count, because we've learned that interrupting counts is a competing priority. And as we did root cause analysis with our count committee, incorrect counts, that also contributes to the outcome that we don't want to have, which is that retained foreign object. So if we can focus further upstream on the incorrect counts, can we correct the process to prevent the retained foreign object? And that would hopefully improve the overall count process, improve quality of care, and improve efficiency, which is not our main priority, but it would be a nice secondary priority. I've heard Doug mention the surgical safety checklist a few times, which at Stanford, that is something that we are prioritizing as well with Universal Protocol. We noticed that our debrief checklist had a few operational components in it. And like we say, we Stanfordized it once upon a time. It was probably due to legacy reasons. It had good intention at the time, but we had to look and reevaluate the true guiding principles with the World Health Organization and what was the best practices intended for the debrief checklist. And with using the black box data and the guiding principle of the World Health Organization essentials, if you will, we were able to remove a lot of our operational components, because we realized, we don't actually need all these things part of it, the debrief. Let's have it that part of the standard work. And that helped with buy-in to do the debrief overall. And I've heard specimens mentioned here a few times, which makes me really excited, because we can network and collaborate on how we're improving specimen handoff, and preventing lost specimens, really, for patients. And we're looking at that at Stanford as well. So what we realized is we don't want to just prevent losing specimens. We want to also look at those near misses, and we're using this technology to do so. I heard Doug mention a debrief, which also gets me excited, because we actually just looked at a clip where the laterality was incorrect. And we discovered this when we looked at the debrief clip. So the handoff occurred between the surgeon and the tech, and the laterality, it was miscommunicated at that point. But we were so excited because the debrief was done. So we celebrated that small win. But we also said, great, you did a debrief. But we could do better, because we had a process gap here. Even though the specimen didn't get lost, we could have done better leading up to that. So it was something for us to evaluate and figure how we could do better, that growth mindset. Now, if we do have a serious safety event, and let's say harm does reach the patient, we absolutely use these clips, like in a root cause analysis, and we're actually doing that right now. So there's such a bandwidth and spectrum of how you can use this data, from the near misses to the actual things that do reach patients. And we get excited, and just hearing how we're all kind of doing the same thing, I get excited and invigorated by it. I just got an email this week from Duke asking how we utilize our clips in root cause analysis. And so I enjoy the networking too part of it, because we're all really big academic medical centers and prestigious organizations, and we should work together really for reducing patient harm, essentially. Thank you.
Thanks so much, Dominique. And so I just wanted to tap into all of your experience there at Stanford. So how have you seen the power of video review help in overall performance improvement, if you have specific examples from Stanford, aside from what you've already shared?
Yeah, so thank you, Jennifer. If you think about all the greatest athletes in the world, and I know we just had our Olympics, so we saw a bunch of them, they watch game tape review to get better, that growth mindset. And that's why I like watching these de-identified clips, as we mentioned, because You watch the clip, it's objective, it's de-identified, but that's how you can learn how to push hard on the process, not the people, to essentially learn from those opportunities. And I think you mentioned at Duke, you did recently the multidisciplinary rounds. We've been really trying to, and we learned that from UT Southwestern. We took that from another organization and grew on that. We've been doing those recently. I think we had our 4th or 5th one just a few weeks ago. But we've been doing the same where we have hundreds of participants from surgery, anesthesiology, frontline staff, and leadership, and we take a clip, or a few clips actually, but a case with the OR black box de-identified, and we use it as a case study and review it. So one that's coming to mind is a patient unfortunately passed away, and they received over 30 blood products in this case. And we used it because we had an opportunity for improvement for sure in the blood administration process. We learned that we were the only area in the entire hospital, in the entire organization, Stanford entity, that is still requiring 2 licensed personnel to sign off for blood administration. And we kind of asked ourselves why. We looked at the policy and procedure, it's not required anymore. And in the clips, we discovered that not only were we still requiring 2 personnel, we were usually using anesthesiologists to do this. So we weren't utilizing our resources smartly. So with this meeting in the forum, we had really good discussion with our stakeholders. We collaborated, and we were able to implement change based off the insights from this forum. And that, it was just incredible because it was a safe space to talk about it. Again, pushing on the process, not the people. An outcome I could share, and I heard discussion about debrief, is back in 2022, when we brought Black Box to Stanford Healthcare, we discovered a discrepancy in our post-procedure debrief performance, because traditionally we do the in-person audits where someone goes in with a clipboard and you audit someone. And if you see me in the OR, you'll probably think, what is Dominique doing in the OR? And do all the things you should do. It's the Hawthorne effect. So our compliance data was coming back, traditional audits, 100%, 100%. But when we had Black Box show up, it was saying, you're more like 20, 29% average, which was a flag for us. So we went on our debrief campaign, as many organizations did. And we really learned the importance of post-procedure debriefs. As people have mentioned here, it's essential for communication and improvement opportunities before the patient leaves the room. But we were able to utilize the video clips and data, and we've been able to achieve modest improvements. And now we're in the 50th to 60th percentile, and we've sustained this over the last year. So I'm excited about that. Thank you.
That's an excellent example, Dominique. And Doug, how about you? Have you used the Black Box technology to look at your compliance with the debriefs?
So we have used it to look at the debrief, and we have found that we have some areas that we could improve. The challenge is then creating educational interventions that can move the needle. But the first point, and Dominique, you said this, I think initially the assumption for most people is that we're 100% or close to 100% in the performance of any aspect of the safety pause. It's incredibly helpful to just start with some data and help people understand that although maybe an audit a few years ago on somebody with a clipboard looked like we were near 100%, when we actually see everyday performance, it's not quite 100%. And the first step is understanding where you stand and what your current practice is. And then the other beauty is that it breaks it down by different aspects. So it's you can see which aspects of the debrief you're not doing as well. And if you're really focused on specimen handling, there are parts of it that you can get those data points, and then you tailor your educational intervention based on those.
Those are great examples, Dominique and Doug. And the analogy to the sports video makes a lot of sense. And as you mentioned, this is our first opportunity in the operating room to look at our performance and see how we can improve. And Duke has looked at a number of unique quality improvement needs, such as compliance with timeouts prior to administration of Exparel in peripheral nerve blocks, as well as standard management and communication when the patient is hypothermic during the surgery. We've also used the technology to look at the completeness of nursing handoffs interoperatively. And we implemented a new process to be sure all the key points were discussed. So this might be a good time to talk about one of the most common concerns when people hear about cameras in the operating room. Everyone's number one question is, will this be used for individual performance evaluation? Dominique, what's your most important piece of advice here?
The answer is no, it will not be used for individual performance evaluations from a staff perspective. And my most important piece of advice is to be patient. And I have to honestly remind myself that as a human being, because I think for this technology, I was an early adapter. I leaned into it pretty eagerly. For our quality team, we review safety event reports that come through, and they are written with a very subjective lens. Some of them are one sentence, even a few words, and some of them are like a novel, and you can really read the energy that the author had that day. And I feel for them because obviously they had a hard day that day. But with these clips, it just gives you in the aggregate data, it shows a different story, and it helps us provide a different picture and a more holistic lens. So I get excited by that, but I have to understand that not everyone with their roles share that same excitement. So I teach myself and my team, let's be patient, because we might it's change, and change is hard. So that's what I would say. But also reassure people that we are not using this for performance. It's really for learning, and just continue to show opportunities for that.
Absolutely,
Jennifer,
it's very important.
If I could just chime in on that, add, I think very importantly, and we touched on a little bit, but with the OR black box, part of the AI technology is to de-identify individuals. So faces are blurred, anything identifying is blurred, including voices. We have done some analyses of, for instance, a code in the operating room, and people couldn't tell who they were in the room. So that will give you some sense of how good that de-identification is. And it's really essential for the very question that you asked about, is about using this and for any sort of reprimand about individual performance. We have built into a charter that we created for the black box that this would never be used for that. And I think us as leaders in our institutions need to really stand by that principle. The guiding principle that we talked about is to improve our team performance so that our patients are safer, and to create a safe environment for people who are people. So they're going to make mistakes at times. The goal is that we can all learn so that we don't make that mistake in the future. It's not to punish anyone.
Absolutely. Great point. For our last topic,
Jennifer, if I may say so, I think
please.
I think in one of the questions in the inbox here, it's very pertinent to what you're talking about. Just like what Doug and Dominic did essentially with their whole system, is we established policies that would absolutely state that this is not to be used for evaluation or employee evaluation or performance improvement. Although the fact is that professionalism can actually be, evaluated by this technology very well, but I think maybe that may come at a later time as people get more comfortable. So one of the people in the questions asked, how do you do it so that, in the collective bargaining with the unions, did you have to talk to them that this is not to be used? And I don't know how the other systems did it, but when we were trying to get legal buy-in into implementing the black box here at Mount Sinai, one of the issues was the union, and I had to meet with the union, and we had to make a very, very strict rule that this is not for disciplinary or performance evaluations, totally separate. What this is only for performance improvement of the institution and of the team. So I think that's important to establish that. And if you do think about it, I mean, I took the lead of other institutions, including Stanford as well as UT Southwestern, that it's important to establish a working group, a group as what Doug referred to as a charter, that has representation of all departments, and at the same time, transparency of what the policies are and the rules and how things are done. Because people are always very dubious about having these cameras in the operating room. What is this being utilized for? So I think it's important to each institution may have a different culture in their operating room, in their institution. It's very important to take the time and partner with the right stakeholders, including risk management and legal even, to determine what is the best way to deal with sensitive issues like this.
Absolutely. Thanks, Celia. And I do think it's important that we uphold these at each of our institutions, these policies and procedures with this core group. Because the minute that it's used for a purpose of individual evaluation, the whole point of people speaking up for patient safety kind of gets broken down. So I think each of us has really focused on this at each of our institutions. So for our last topic, let's spend a few moments talking about what's next for each of our organizations. For example, at Duke, our Black Box Committee is focused on KPIs, and we break them down by education, culture, and quality and safety. So currently, we're focusing on culture and quality improvement through increased engagement of frontline staff. We're doing this in multiple ways. One is that we're educating them about the technology and teaching them how to flag a case for review. And once the cases are reviewed by our committee, then we determine if a system level change is indicated, and then invite the frontline staff to be part of the team and lead the team that gives formal recommendations to our peri-op exec committee for a better practice. We also plan to review our timeout and debrief process to identify opportunities for improvement. And we're in the process of giving all surgeons access to the Explorer technology to review their own cases and to use them to teach their residents. And Celia, so what's next for Mount Sinai?
Mind you, we're nowhere near solving our problem with the checklist. I mean, we do very well with the timeouts, but like everybody else in this forum, the debriefing is a challenge. But what makes this platform so good is that you can adapt it to the priorities of your institution. What you think is important, a debrief in the Brigham may be totally different. The setting here in Sinai, maybe all our people are gone by then. I mean, what you need to do is establish something that is workable within your institution with the same consistency that is also consistent with the WHO standards. As that, and I think the nice thing about the black box is you can work with their staff to design it so that it works each way. So we're still working on that. However, we actually started rolling out Room State. I'm not sure it's really a support system that will eventually optimize schedule, block schedules or schedules within the operating room and the flow. We know that we have issues with room turnover and as well, and we want to implement steps to improve this utilization. It's important that optimizing utilization will inevitably have very important downstream effects on our block schedule. Block schedules are always the problem in every institution, how to make it so that we are optimizing the operating room. So this option of having this room state technology and system with black box is really, hopefully, we are hoping that with their accurate data, we can actually solve our issues with block scheduling as well as staffing in the operating room, because by increasing turnover, we can utilize the staff more, and by utilizing the staff more, maybe reduce overtime pay and it makes a difference on the bottom line. We are also trying to support our residents in being able to use the Explorer to create their own video library, and we've incorporated it into the curriculum so that we have a group of faculty that will serve as coaches for them as well as evaluate their videos. And hopefully, this whole Explorer will also be open to all our attending surgeons because it's not only the residents that have that. And thirdly, we are looking at our KPIs and outcomes data, like I said, on a monthly basis. We have ongoing reviews and working with our EHR. For us, it's Epic. We're able to come up with the outcomes. And hopefully, we can tie that over to our, how effective our safety checklist performance is, as well as intraoperative conditions, because we're already hooked up with the anesthesia for hypothermia, bleeding, hypotension, and all of those other factors. But before we run, we learn how to walk and work on our basic, performance measures here that we need to optimize.
Thanks, Celia. And how about you, Doug? What's next for your institution?
So we've considered a lot of those ideas that Celia just presented. We are we're not quite as far along, I think, as some of the other institutions. And to me, the real next step for us that I'm excited about is to do the interdisciplinary grand rounds that you all have discussed doing in your institutions. We have had a chance to review a code that occurred in the OR that was handled incredibly well. We've done it in sort of different group M&Ms, but not in an interdisciplinary way. And what I really look forward to is getting all disciplines together to review. And actually, I like the idea of turning M&M sort of on its head. M&M is mostly focused on cases that go poorly, and how can we avoid that? I'm really intrigued by the ability of the black box to help us identify a case that went well, and how can we all learn from the performance of some other team, or our own team if we were in the procedure. But I'm really excited to do some interdisciplinary grand rounds where we focus on good performance. I think that's really powerful for creating that culture, that positive culture around the black box and a safe environment. So that's what I hope for.
Yeah, absolutely. This technology has proven to get all disciplines in the OR together at multiple institutions to work toward a common goal. And it sounds like even if we reviewed one case at each of these institutions, we found things we need to work on and we're able to improve patient safety. So it's been extremely helpful in the culture building piece as well as the quality improvement piece. And how about you, Dominique, at Stanford? What's next at Stanford?
Yeah, actually, we are going to start looking at the culture of safety lens with just using and leveraging the technology. We had a really good discussion at our steering committee when we met last time. We looked at a clip which was initially flagged for clinical practice reasons. And as we reviewed the clip, we realized there was a lot more to the clip than originally flagged. And what Doug was just hitting on, I love, because there is a methodology called success cause analysis, and we should be focusing more on the standard and not the exception, because that is what you want to learn from, is the best practice. So we had such a rich discussion with surgeons. They were very engaged on how are we giving tools to everyone in that room. If there is a concern, how are we giving them the tools and the systems to say, hey, I have a concern, here's why, X, Y, Z, to make sure we're all feeling safe to speak up and it doesn't get escalated outside and all of this follow-up that we all have to deal with. So that's what we want to leverage the technology for. And we're using our resources in the hospital to embark on this journey with us. So that's what we look forward to. And I saw a question. We actually have the technology in our rooms that include interventional radiology and cath angio. So interventional platform is holistic. It's not just the operating room. Thank you.
Thanks, Dominique. All right, so this has been a great discussion. Let's move over to some Q&A now. For our first question, and I'm asking this of all of our panelists, what strategies have you found effective for getting surgeon and staff buy-in when rolling out the new AI workflow?
I'm happy to start. I would say the biggest important aspect is around communication. So we planned, and I actually learned this from Celia, I must admit, and from others in the SSN, but we were planning the black box for over 2 years before we implemented and turned it on. And by planning, not only was it some of the behind the scenes infrastructure that we needed to discuss within the consent process and compliance and quality and safety, but also around communicating it to staff. And that's to every staff that goes into the operating room. And so surgeons, anesthesiologists, nurses, environmental services, all those groups need to be educated. And honestly, they need to be educated and have multiple forums to discuss this. Not just one time, but we really tried to do multiple sessions with all of those groups to help them understand why we think this is important, but also to get feedback from them on their concerns. And we used that over those 2 years to really make sure we had a tight process, that we felt like we hadn't left any stones unturned. And sometimes we changed our processes based on feedback we'd received from them. I think communication was the most important aspect of ultimately buy-in. And that's not to say that everybody agrees, but then I think ultimately everybody feels like they've had an opportunity to speak up about it, and also have gotten feedback or have gotten some understanding of why we would undertake this process.
I think Jen realizing that this is the biggest stumbling block first before you implement the technology is the very first step. Because if you ignore that, you're never going to succeed or get a buy-in. I learned the term socialization from surgical safety, and now I know what it means. And it's not a one-time deal. It's almost like a continuous, repeated reinforcement so that it doesn't threaten the surgeons or the nurses or the staff's, way of flow or independence in the operating room. And I think what we did in the beginning was we never focused on the issues of case reviews or tapes. What we did is we were honest and we said, let's just collect aggregate data for 24 hours a day. We're not collecting data against one particular room, one particular service, or one particular person. It's aggregate data. That's one. And as soon as we were able to convince them that it was aggregate data, they were a little bit more comfortable. A second thing is, I think, sharing the data with people, I think, is very, very important. It goes back to the transparency. And third is finding useful ways where, Black Box had a benefit, and celebrating, like what everybody's saying. We don't always have to dwell on what went wrong, but celebrating on the good things that we do well, and I think that will help get a long way with having a buy-in. But I think a tremendous amount of effort, even just from going from 2 rooms to 17 rooms, was just as difficult. Convincing them to, even if it was already around for 2 years, now to 17 rooms. But the benefits are really tremendous. And a lot of people now are actually asking for it in their rooms.
No, that's a great example, Celia, especially when you work on transparency and showing people what are you doing with the data, and this is what it looks like, and this is what we found, and these are the things that we can work on and do better. I think people have a lot more engagement at that point, and realize the value of the technology. And here at Duke, we did a lot of socialization up front as well. But we actually found the multidisciplinary grand rounds where, nurses were sitting next to surgical attendants, sitting next to surgeons, and everyone kind of looking at each other like we're all here for the same thing. And then reviewing one case together actually brought the most buy-in and the most engagement. We had 60 people sign up for task forces to work on these quality improvement initiatives. So that was kind of our big jump in getting buy-in from staff and surgeons and anesthesiologists. All right, moving on to the next question. What were some of the biggest cultural or change management hurdles that you faced when deploying AI in the surgical area? Dominique, I don't know if you want to comment on that one.
Yeah, I can add. So I think, AI, we're all lucky to have some really cool technology that not all organizations have this luxury of having. So I will just state that. But with having some of our teams say, we have this shiny new car, it's exciting, but you still need to know how to drive it. And change is hard. And I can't keep overstating that because not everyone is ready to get in that car with you. And they don't trust that you can drive it safely. And that's okay. When we went to electronic health records, people were not okay with that. People like their pen and paper, pencil and paper. So we have to respect where everyone is because some people might not be ready to embark on that change journey. But what we just all said about socialization, you have to be patient and just keep giving examples and be consistent with going back to your guiding principles of this is for learning, not for punishment, and stay true to those core values. Then people will start to trust the process. That's it. And then once you start to see some maybe cultural opportunities for what your environment is really showing, I think that is the opportunity for leadership to lean in and say, okay, what are we going to do about this? Because it will offer some insights. But change is hard, no matter what kind of change we're talking about, a new patient population for staff or transitioning to a new technology. This is very innovative technology that we're still getting used to as a world. So I feel lucky, but also understand that this is different, and we have to meet where they're at.
Excellent. All right, and moving on to the next question. With all the possible topics for process improvement, how do your teams decide on the organizational focus?
I can address that. For our group, for the core group, what we call the working group of the black box, we actually have made a rule that for 1 quarter, we would, as a group, decide what are the indicators that we think we should work on specifically. Review the data after 6 months and then identify again indicators. The issue is that every department that has the technology has a different thing in mind that they think is important to them, that is sometimes not relevant to the other departments. So we establish as a group what are the priorities we want to track for the first quarter or the next 6 months, and typically they are priorities that are in line with the institutional's priorities. That way you also increase compliance and increase not only compliance within our own checklist but CMS, because there are a lot of other requirements that also come into play. So we establish it as a group and then reevaluate the data after a certain period of time. And if we're making progress, we move on to the next other 3 indicators that we think we should work on.
I think really important to remember is that the black box is just, and the data we get are just one aspect of the quality improvement data that we collect. We collect data about mortality and surgical site infections. We have safety report data. Somebody put in the chat and asked if this replaces that. It has potential to replace that or at least make that easier, but this just adds to the data, and we need to make the data that we receive part of the discussion, and the groups that are focused on quality and safety need to put all of those data together. The black box is quite illuminating into what is going on in the operating room, which is an area that we've all struggled with getting better information about what's going on in there. But it's not the only data. It should be part of that catalog of quality improvement data that we collect.
To tag on to that, and there's a question about making sure institutional awareness of patient safety trends, and not that this is a silo. I love that thinking. And to just what Doug was just sharing, for our quality subcommittee, we've really been intentional that our KPIs and our priorities are related to the operational plan. That it's not what Dominique thinks we should do and just, making up stuff. It is a clear tie-in to the goals, but we are leveraging this technology because it is just a data source. It's not going to be potentially causative. It's probably more correlative, and we need to put it all together in the big picture. But we've really integrated our patient safety committee and other team committees and members into our subcommittee so that we can all paint the bigger picture here and make sure we're working on things together so that there is no siloed work. Also, so that we can optimize our resources and work together, work smarter, not harder, because you don't want to do redundant work. But absolutely, we have to make sure that we are doing work that is contributing to the operational plan. That's what our teams have really been focused on, or the strategic plan overall, because I don't want us to figure out like, oh, this really contributed to nothing. And I do enjoy that a lot of the metrics and stuff that they come out of the process steps, you can tie it into those goals pretty significantly. But again, you have to really think about, is this going to cause it? Most likely not, but we can try to figure out how it can correlate.
Absolutely. I love that integration with the initiatives that are important to the hospital and to the health system. I think that is how we add value to the system. And so another question, do you believe that collaboration across institutions would help truly get better solutions, or do you believe this should be technology used just at each institution individually?
Instinctively, I would think collaboration between institutions is so valuable. I mean, the things I have learned and probably prevented a lot of mistakes in our implementation comes from talking to people who've had it at Duke, at Stanford, and at UT Southwestern. Not only from in the standpoint of implementation, but also from the standpoint of utilization of the data, standardization of the data. I mean, a lot of those things are cross-institution, would probably have some value. You cannot again go back to saying you're going to work in a silo and have your own personalized data, because that's just not going to work. I mean, important registries are represented by large numbers of data points, and that is, I think, an important fact that we have to continue to collaborate with other people, with other institutions.
I completely agree. I was just going to share, so with SST, we have work groups in addition to just the metrics in the institutions, but we collaborate. And the nursing work group, we meet quarterly, but we also meet in person now. And we're actually like coming together and saying, this is the work we want to do. We came up with an education module of an ebook of what we want to do, just-in-time training for staff. And it's actually the work in between and collaborating not only on the data, but how do you come up with these processes and what lessons learned did, from an opportunity, a failure, or, hey, this really worked. So it's all of that. And I would not have these connections if it wasn't for the network. So I really enjoy collaborating because it's a safe space and there's so many connections made.
Excellent. And Doug, did you have a comment on that one?
Yeah, I would just echo that. If there's something I've learned through this process, is that we all have the same problems and we're all trying to fix them independently. And I think that coming together as a community who's using this technology, we have so much, there's so much more power of the intellect that we would bring, but also The ability, if one place is able to come up with solutions, we can share it. I think that's what we all are hoping for through this.
Absolutely. So one more quick question here. From an ROI perspective, which use cases could show the most tangible return on investment? So for AI adoption in the OR environment.
Good question. I think eventually it should be all cases, but you want the high number cases so that you can have enough data to be used for the AI technology. I mean, the fact is that those short cases, for example, a gallbladder is a classic example. The short cases that are predictable, that you can presumably determine how many you can put in one room, how long can you keep a room going, how long what kind of staffing can you have for that room, and what else do you need? You just need radiology or something like that. So the high volume cases in the beginning are the best bet, I think, for ROI, because you can optimize utilization of the OR, staffing, as well as, you don't have too many other things down the road that you need to consider to look at ROIs. And those are the low-lying fruits that could be solved pretty fast, in terms of the block schedule. And I think after that, everything is quite possible. Everything other than maybe the very, very, very high acuity where you have unexpected events that can happen of 50 units of blood or something like that, then that's a little bit difficult. But if there is some regularity, that's the first target we're looking at.
And Doug, how about you?
Well, I agree with
how many?
Julia. That is where the efficiency and the ROI is. Although I would also say very hard to measure. But if this technology and the safety culture it creates eliminates one major adverse event, that saves a patient from that. It saves providers from being part of that. And that I think is the real power. It's just so hard to measure. But that's what I think drives many of us as we embark on this.
Yeah, conceptually, you want to look at your cost of poor quality, but also tactically, you can just look at how much you're spending on doing audits and with your clinical staff, and then look at your aggregate data, and that is saving with ROI.
Excellent. Looks like we're coming to a close here. I'll just look at one more question here. Given the variability in surgical procedures across the institutions and in surgeons, how can AI models be trained to generalize well across diverse data sets? Anyone have a comment about that?
I can just say my sense is we're not quite there yet, but that is why we're starting on this, and that's the power of this big data. A lot of other industries are using big data to try to gain insight into their problems, and we can do the same in surgery. I'm not an expert in the AI. I don't know that anybody else on the call is, but I trust that we can, as more and more institutions take on this technology, we'll be able to harness that data power to start to generalize across multiple procedures and surgeons and institutions.
I want to echo what Doug is saying. I mean, it's too early, but this is the value of AI. The potential is tremendous, but you need still so much data. If we thought that way about predicting consumer patterns, think of how diverse consumers are, but now we can predict what they're going to buy on a Tuesday, in December. So the fact is that is the biggest, aspect there. But again, as Doug said, it's too early. It's too early. We don't have enough data. But once we have enough data, we can actually predict these patterns.
Well, thank you both for your comments. And this brings our session to a close. Thank you all for participating. Thanks to all of our panelists. This was a great discussion.